respected seniors, colleagues and friends. In fact, I feel vindicted. Why? 90 minutes of prime time was given to talks on statin, ezetimibe and inclisiran and Repatha. Only 15 minutes were given to me to talk against statins. Actually, in real world, I should be talking 90 minutes and they should be talking in total 15 minutes. But still, the real world is that statin can provide you with breakfast and lunch. Talking against statin, chai bhi naseeb nahi hoti hai. So I am talking against statin. Khotu na lagadta. Why statin matters? Everyone has talked 90 minutes of statin. Statin saves life. Statin prolongs life. We have enough data on this. It reduces mortality in acute events and significantly reduces repeat events. So it's a good drug. Nilesh had said 38.7 milligram decrease in LDL leads to 21% decrease in CV mortality. A big number. I agree to that. The choice is yours, whether you want a stent or whether you want a statin. So statin is a $28 billion molecule last year and which is growing exponentially. So it's a big molecule. So why there is intolerance? Is it true or is it just an hype or is it an overhype? The answer is yes, it is true, yes, it is hyped and yes, it is overhyped. What is it? Why it matters? Statins are the top 3 prescribed molecules in the world. And even a small percentage of if there is an adverse effect, the absolute number is so big that it gets highlighted. The adverse effects or intolerance reported in randomized trial was 5 to 10%. In registries, it was 15 to 20%. And in observational data, what we see in clinical practice is almost 25 to 30%, or even more. I'll come to that. So it's a big number. There is intolerance, large in clinical practice, but it is hidden. We need to unhide those things. And even the data says that if you stop statin, someone said in the lecture, I think Nilesh's slide, the statin stop karwathi, all the graphs become higher. I forgot that trial. So if you stop statin, you are risking the patient to an acute cardiac event. So you are not supposed to stop statin. So આમાં વચલો રસ્તો શું છે? What is the definition? International Lipid Expert Panel in 2015, 2022, there are many definitions. But remember, the crux is this. Inability to tolerate statins in required dose to attain that target level. Everyone has said target, target, target. It is not, if you have 10 milligram of statin with an LDL of 110, it is not ideal. You have to have less than 70, and if you increase the dose of statin, a patient has myopathy, then it is intolerance. So inability to tolerate statins in required dose so as to attain the target level necessary to reduce CV risk. The ultimate aim is to reduce CV risk. So that level of LDL has to be achieved. Stopping treatment resolves symptoms, re-challenge the patient, the symptoms appear. So that is statin intolerance. Of 2 different statins, Rozua once, Atorva second time, or vice versa, you give Pitava or whatever. But this is the clinical definition of statin intolerance. What are the mechanisms? Multiple mechanisms. I mean, they are there, but just to enumerate, mostly it is drug-to-drug interaction. It acts on liver. So liver is a factory of metabolism for most of the things. So anything that is metabolized by CYP450, CYP34A, all that thing gets altered levels of statin. Mitochondrial dysfunction, HMG coenzyme reduction inhibition leads to decreased synthesis of coenzyme Q10. Now this was overhyped once upon a time that because of this deficiency, patient has myopathy or muscle pain and other adverse effects which has not been found. And there are certain genes, there are certain people who are prone to muscle pains or adverse effects. So there are genes also which have been found out. host of drugs, આમાં કંઈ દેખાશે નહીં, પણ most of the cardiology drugs produce drug-to-drug interaction with statin. Cordarone, antifungal, calcium channel blockers, colchicine, digoxin, fibrates, niacin, even our Brilinta, ticagrelor, warfarin. So polytherapy is one of the risk factors for statin side effects. Who are the patients who may get side effects? Elderly patients 75, 80 and above, females, and low weight patients, and Southeast Asian. We are the underprivileged class of the world. આપણામાં બધું જ વધારે થાય છે, ખોટી વસ્તુ વધારે થાય છે. We are this. On top of it, patients of hypothyroidism, always check thyroid profile in patients on statins. Hypothyroid aggravates statin intolerance. Patients taking alcohol, much has been discussed. Alcohol is metabolized in liver, statin is metabolized in liver, so alcohol is a big no. Pre-existing liver disease, because as I said, liver is a prime organ of metabolism for statins. Patients with CKD. And most important is polytherapy. એક પ્રિસ્ક્રિપ્શનમાં 5 થી 10 ટેબ્લેટ તો હોય જ છે. All these tablets are interacting with your statin levels. So we have to be very careful in writing. Just don't write tablets just for the sake of it. And this is my most important slide. Who are pseudo high risk patients? 50% ડોક્ટર લોકો ટોલરેટ કરતા નથી. All medical professionals, I have most of the patients who are medical doctors who say સાંજ પડે ખભા દુખે છે, કમર દુખે છે, etc., etc. So these medical, because we know it is a nocebo effect, okay, we are going to have these side effects, and this is the reason why medical professionals have maximum side effects. 50% of the patients or doctors. And a very interesting word. Anyone knows what is this? Who is a Webakuf? He is a person who foolishly believes in every word or news on internet, social media or WhatsApp to be true. If you see Google search data, 99.7% search is on statin side effects and only 0.3% is on statin effects. So 99% statin ચાલુ કરો એટલે સાઇડ ઇફેક્ટ જ જોવે જ લોકો. સો ધીઝ વેબાકૂફ્સ એ મગજમાં આવી ગયું કે આ સ્ટેટિન ખાધી છે એટલે સાઇડ ઇફેક્ટ જ થવાની છે. All these are nocebo effect, and these two are the ones who are the culprit for statin intolerance. So these two very important. Forget Asians and Indians and whatever. So Webakuf. What is the diagnostic approach? Detailed history, clinical examination, rule out, as I said, thyroid and rheumatoid arthritis, or someone said there is pan inflammation that has to be taken care of. Treatment wise, once you discontinue, restart after 2 weeks. If patient has recurrence of symptoms, indicates patient has intolerance. And there is this very excellent smooth statin associated muscle symptom index. I'll come to that later on. What is most common side effect is myalgia, bilateral shoulder, big joints and big muscle groups. Single side, it is not statin induced. It is bilateral hip, bilateral thigh, bilateral calf, or bilateral shoulders. CK levels are normal. If CK is between 4 to 10, it is myositis and rhabdomyolysis, which is rare, which is associated with high creatinine and cola-colored urine. There are certain autoimmune disease also, which I will not come to that. I'm not sure whether you can see this, but bottom of this is statin-related myopathy. Asymptomatic CK elevation incidence is 15 to 20%. Myalgia, CK is less than 4, myopathy 4 to 10. And as the CK level increases, the level of myopathy increases and it becomes extremely rare. Clinical assessment, this is the score which I was talking about, which is the distribution of the muscles, the starting of the pain, less than 4 weeks, more than 4 weeks, more than 12 weeks. There are numbers to that. And if the total is less than 7, it is unlikely, and if it is more than 9, most chances are that you have muscle related side effect based on statin therapy. એટલે આ એકવાર ઇન્ટરનેટમાં મળી જાય, જોઈ લેવાનું કે ભાઈ આ સ્ટેટિન ઇન્ડ્યુસ છે કે નહીં, so that you can tailor your treatment. Very interesting trial. British Heart Association did this study, Samson trial. They gave 1 bottle of atorvastatin, 1 bottle of placebo and 1 empty bottle. બધાને 3 બોટલ આપી 3 મહિના સુધી. જે બોટલ ખુલે એ બોટલ ખાવાની. ખાલી બોટલ હોય તો 30 દિવસ ખાલી બોટલ, 30 દિવસ સ્ટેટિન ને 30 દિવસ પ્લેસિબો. And what they found was, when no one knew it, it was internet based. Daily they had to say કે muscle pain થયું, liver pain થયું, આ થયું, તે થયું. The effect was, research showed that many of the very real side effects of taking statin were result of knowing that you are taking statin. They were told કે આમાં statin છે. So મગજમાં statin આવેલું હોય તો side effects થાય. It is like Shakti Kapoor in the movie કે ઇન્ટરવલ પહેલાં ગમે એવો સારો દેખાતો હોય પણ આપણને અંદરથી હોય જ કે ઇન્ટરવલ પછી તો એ નાલાયક જ થશે. It is statin is like this. If you start taking statin, you will feel at some time or other you are going to get side effects. So that is a nocebo effect, and this was published in British Heart Journal, and after this 90% of the patient could tolerate. So it is just reassurance and re-challenge telling them કે ભાઈ આ સ્ટેટિનનું નથી, મગજમાં છે. So it is all in the mind. So myalgia is over, risk is there in high risk category, but then you re-challenge, you can still do it. Second side effect is hepatotoxicity. It is asymptomatic and reversible. The moment you stop it, the enzymes may come down. It is dose dependent and symptomatic elevation of liver enzymes. Elevation of liver enzymes. Persistently elevated enzymes of more than 3 times is less seen in around 3%. So 97% of the patients should not have a problem with more than 3 times elevation of liver enzymes. Bilirubin typically remains normal. The day bilirubin goes up indicates it's a problem and needs to be investigated. So statin induced, there may be elevation of OTPT, but remember bilirubin remains normal and you should not be worried. Fatty liver, everyone has it in Gujarat because of the high carb diet. Baseline ST-PT, OT remains 45-50, upper normal, but then statins are indicated. Do not withhold statins because in fact they are proved to be beneficial if you give in fatty liver. This is the global data. Ultimately what you are worried is myolysis, ani andar liver failure. The incidence is 1 per million, which is extremely rare. So liver is, I think we can do the SGOT-PTA levels, but don't worry much about it. It is not much of a problem. Biggest challenge, new onset diabetes mellitus. It is big hype. Small, all words are important. Small but measurable increase in new onset diabetes mellitus with 2 things, higher dose and predisposed individuals. Not everyone gets it. Remember, there are people who are going to get it in future, they get it early, and there are on the dose which are higher. 40 milligrams of atorvastatin, 20 milligrams of rosuvastatin for a long time, it produces diabetes, but it is a definite phenomena which occurs. Jupiter trial in 2008, which was the first one which came out with this diabetes controversy, and 25%, remember 25% had altered A1C at that time, and that is what real people started working on, why patient gets diabetes. Subsequently meta-analysis was done, કારણ કે it's a $1 million molecule, હવે આમાં diabetes આવી જાય તો ધંધો જતો રહે. So they did a meta-analysis study, they could find some statistics. They say that it unmasks your diabetes in prone individuals by 3 months. If I was to get diabetes in 2026, I will get it 3 months earlier in January rather than getting it in April. That is what the guideline says. But in reality, the scene may be little different. Recently, the cholesterol trial group in 2023, they came out with this number, 1 to 2 cases per 1,000 patient years. Statins are safe. Ultimately, you have to prove statins are safe, whether you prove it by statistics or whether you do by anything. But they came out in 2023, કે એટલું બધું થતું નથી, but honestly speaking, it is a problem. How does this happen? I spoke to Nilesh also in the morning. Statin causes reduced insulin sensitivity. Ultimately, we are all talking of insulin resistance for diabetes. Statin causes reduced insulin sensitivity. There is a beta cell secretion which goes down. There is beta cell apoptosis, and there is GLP-1 reduction. Now, GLP is in the market. There are many theories. These are the ones which I could understand and could translate to you people. Okay, these are the mechanisms by which diabetes is a definite number that happens if you take statins. પછી તો સ્ટેટિન તો દેવાના જ છે એટલે કંઈક તો ગોતવું ને. તો બેનિફિટ્સ ઓફ વેસ્ક્યુલર પ્રોટેક્શન આઉટવેઝ ધ રિસ્ક ઓફ ન્યૂ ઓનસેટ. સો સ્ટેટિન ભલે ડાયાબિટીસ થાય, ભલે ઇન્સ્યુલિન સેન્સિટિવિટી ઓછી થાય, give metformin, but then rosuvastatin has to be given because the benefit they could calculate as 5 times. This is the equation, very interesting thing. Of 250 patients given statin, 1 will have diabetes and 9 will prevented death. This is some ACC, AHA ke Mayo Clinic mathi I got this number. So 250 patient mathi ek jana ne thase for 5 years if you give 40 milligrams of atorvastatin, and they say that this is a big number. So remember that in your clinical practice. Diabetes does happen, but then you need to be careful. Other adverse effects, આ બધા મેઇન આ 1, 2, 3 થઈ ગયા. બાકીનું ચણા મમરા શું છે? Brain dysfunction, cognitive memory, hemorrhagic stroke, neuropathy, psychiatric disorder, maniac, and even suicide reports have been given, of course, which has not been statistically proven. Renal dysfunction, cataracts, GI issue, etc. If you see the list of side effects on Google, except pregnancy, everything is possible. So it is your call whether to get pregnant or to get side effects. That's a different thing. Anyway, so 3 main effects: myalgias, hepatotoxicity, and the third thing, diabetes. According to me, diabetes is a big thing which we need to take care. How do we manage? You confirm that patient has side effects. Statin, and statin, they are the only drugs to prolong life, prevent MACE, and prevent side effects, prevent coronary events. So restart with a lower dose. આજે રોઝુવા 10 બંધ કરી તો એટોરવા 5 ચાલુ કરો, 5 બંધ કરી તો બીજું કંઈક ચાલુ કરો. Even changing the company brand, પેશન્ટને ઘણીવાર સિમ્ટમ જતા રહે છે. I don't know why, but it happens. રોઝુવાસ્ટેટિન 1 આપો ને રોઝુવાસ્ટેટિન બીજી આપો કંપનીની, સસ્તી મોંઘી કરો તોય ફરક પડી જાય છે. So I don't know what is it. It is a nocebo or whatever it is. But change the brand, give a 2-week interval, and then redo it. Switch to hydrophilic statins. Atorva and Simva are lipophilic. Rozua karo. You keep on changing. Rechallenge works in most of the cases. And it has been proven some statin is better than no statin at all. So always after 2 weeks, rechallenge the patient with second statin. I started with my definition that you have to attain the target. હવે એક સ્ટેટિન ઇન્ટોલરન્ટ છે, તમારું ટાર્ગેટ નથી અચીવ થતું. All of these people have said use ezetimibe, 10 milligrams of ezetimibe with low dose statins. Improve it trials said about 17% to 28% છે. But remember, statins are the only drugs which can prolong life and reduce MACE. All other non-statin drugs, despite whatever statistical claims, they do not have protective effect. Numerical reduction is significant, but life benefit is not there, significant. Same is with bempedoic acid, myopathy ન થાય, but then bempedoic I think clear 3-4 there are clear trials, 15 to 17, 13% reduction. PCSK9, 50% reduction. Patient come with LDL of 9, 10, 14, but then it is a numerical reduction. There are trials which they have proven that it improves MACE, but it may or may not be so. Inclisiran is the new kid in the block which is very hyped. 50%, 60%. Inclisiran upar LDL level goes down to 10, 12, 15. Life MACE benefits not as significant as statin. So still it is only statin, and statin. Supplements, આપણા બધા સપ્લિમેન્ટના શોખીન છીએ અને myalgias respond very well to vitamin D supplements. Coenzyme Q10 once upon a time was a good supplement, but there is no conclusive data and address secondary causes. Hypothyroidism is a big thing and a polytherapy is another big thing. આ બે વસ્તુ have to be treated. So final slide within time. Always statin is required. Statin vagar you can't treat heart disease or vascular disease. So I agree with the other people that statin to devana જ છે. You may combine with other drugs if patient is partially or completely intolerant to attain the target. To get the target less than 70 or 55 is must. You add ezetimibe or you add bempedoic acid. And if patient has side effects, reassess, give a statin-free interval and then again restart the drugs. But ultimately it is only statin, statin and statin and continue with your statins. Thank you all.